COPD, stable management. The NICE updated its guidelines on the management of chronic obstructive pulmonary disease in 2018. The management includes two main categories: general management and pharmacological management. Firstly, general management. It includes smoking cessation advice, including offering nicotine replacement therapy, varenicline or bupropion, annual influenza vaccination, one-off pneumococcal vaccination, pulmonary rehabilitation to all people who view themselves as functionally disabled by COPD. Now, let's move to the pharmacological management. In pharmacological management, we use bronchodilator therapy, a short-acting beta-2 agonist, SABA, or short-acting muscarinic antagonist, SAMA, is first-line treatment for patients who remain breathless or have exacerbations. The next step is determined by whether the patient has asthmatic features or features suggesting steroid responsiveness or not. There are a number of criteria NICE suggests to determine whether a patient has asthmatic or steroid-responsive features or not. They include any previous secure diagnosis of asthma or of ATOB, a higher blood eosinophil count. Note that NICE recommend a full blood count for all patients as part of the workup. Substantial variation in FEV1 over time, at least 400 ml, or substantial diurnal variation in peak expiratory flow, at least 20%. If there is no asthmatic features or features suggesting steroid responsiveness, then add a long-acting beta-2 agonist, LABA plus long-acting muscarinic antagonist. But if there is asthmatic features, or features suggesting steroid responsiveness, then take LABA plus inhaled corticosteroid. If patients remain breathless or have exacerbations, offer triple therapy, long-acting beta-2 agonist, LABA plus long-acting muscarinic antagonist, LAMA, plus inhaled corticosteroid. NICE recommend the use of combined inhalers where possible. Now, let's talk about another medications that may be useful in the treatment of COPD. Let's talk about oral theophylline. NICE only recommends theophylline after trials of short and long-acting bronchodilators or to people who cannot use inhaled therapy. Oral prophylactic antibiotic therapy. Azithromycin prophylaxis is recommended in selected patients. Liver function tests and an ECG to exclude QT prolongation should also be done, as azithromycin can prolong the QT interval. Mucolytics should be considered in patients with a chronic productive cough and continued if symptoms improve. Phosphodiesterase 4 inhibitors. Oral phosphodiesterase 4 inhibitors such as roflumilast reduce the risk of COPD exacerbations in patients with severe COPD and a history of frequent COPD exacerbations. NICE recommend phosphodiesterase 4 inhibitors if the disease is severe, defined as a forced expiratory volume in first second after a bronchodilator of less than 50% of predicted normal, and the person has had 2 or more exacerbations in the previous 12 months despite triple inhaled therapy with a long-acting muscarinic antagonist, a long-acting beta-2 agonist, and an inhaled corticosteroid. Now answer this question. You are reviewing a patient with chronic obstructive pulmonary disease, COPD, who remains breathless despite using a salbutamol inhaler as required. Their FEV1 is 60%. There is no history of asthma, eosinophilia, or FEV1 variation. What is the most appropriate next step? Long-acting beta-2 agonist, LABA, or inhaled corticosteroid. Long-acting muscarinic antagonist plus inhaled corticosteroid in a combination inhaler or long-acting beta-2 agonist. Long-acting beta-2 agonist or long-acting beta-2 agonist plus inhaled corticosteroid in a combination inhaler. Long-acting beta-2 agonist or regular combined short-acting beta-2 agonist plus muscarinic antagonist. Combivent. Combined long-acting beta-2 agonist and long-acting muscarinic antagonist. If you know the right answer, put it in the comments. Thank you so much for watching. I hope you found this video helpful and enjoyable. Don't forget to like, comment, and subscribe for more content like this.